So I'm going to just do this. Great. So it's been fun chatting with you, Raquel. Now we'll get really official. So welcome to everyone who is joining us now. And as I said earlier, happy solstice and happy spring. It's really feeling like spring in Boston, which is a really welcome thing. So we're really lucky to have Raquel Bennett here today. She's going to talk about the current landscape of therapeutic ketamine. So Raquel is a psychologist and a ketamine specialist from Berkeley, California. So you definitely have spring there, I'm sure. She primarily works with people who are living with severe depression, bipolar disorder, and or suicidal ideation. Dr. Bennett is fascinated by the antidepressant and anti-obsessional properties of ketamine, and she's been studying that since 2002. She also has a long-standing interest in the ketamine, in the psychedelic and mystical properties of ketamine and the potential for this medicine to be used for spiritual exploration. Dr. Bennett is a founder of the Kriya Institute and the Kriya Conference, which are both devoted to the use of ketamine in psychiatry and psychotherapy. She's given hundreds of lectures worldwide and trained thousands of clinicians on the safe and legal use of ketamine in clinical practice. You can learn more after her talk by checking out her website at the Kriya Institute, which is KRIYA. And as I said earlier, that many of us have heard Raquel, but that didn't mean we didn't want to bring her back because she always has so much to teach all of us. So thank you so much, Raquel, and I'll pass the baton to you.
Oh, thank you. It's an honor and a pleasure to be here. I hope that you can hear me and see me okay. Let's just go ahead and let's just dive in. I want to start today with some gratitude. Thank you so much to Dr. St. Gore and to Sherry Reyes. I hope I'm saying that correctly, for making this happen today. I'm honored to be here. So thank you. Let's see, a little bit more about me. Yes, I'm a psychologist in California, trained in contemporary and relational psychoanalysis. I work in collaboration with medical doctors, which makes the work with ketamine legal. That's important. I want to make sure that I say that I have no conflicts of interests nor any disclosures of any kind. I'm not taking money from any pharmaceutical company or anything like that. I'm a free agent here, and so I can speak freely about my thoughts on the field. So no conflicts. And I like to start these talks by sharing that my interest in this topic is personal. It's academic, but it's also personal. I wandered into underground ketamine treatment myself 20 years ago in 2002. And I thought to myself at that time, this seems to have some pretty rapid acting antidepressant properties. And the people who were treating me said, no, that's not possible. And I said, no, but seriously, I think somebody ought to study this. And they said, why not you? And so here we are. And I always want to share that for two reasons. Number one, I've openly been a ketamine patient myself for 20 years. No shame in that, helps me stay well. And much of what I know about being a ketamine provider and a ketamine teacher comes out of my own experience as the patient. And so for that reason, I think it's really valuable when possible and when legal. I think it's really important for clinicians to have direct and personal experience with these various psychedelic medicines, again, as the law permits, because I think it really informs our clinical practice. So I just want to put in a plug for that. So let me tell you what's on the agenda for today. This is going to be a conceptual talk to help give a framework for understanding what's happening in the exploding field of therapeutic ketamine. It's not a training per se, but Renee, if you can put the link for some of the trainings in the chat, that would be amazing. I'm being assisted today by my friend Renee. And I wanted to be clear that I'm not training this year. I'm actually on sabbatical. So when I mention trainings, I'm not advertising my own services. I'm not taking new clients at this time, nor consulting clients. But rather, I'm going to give you some resources that you can utilize, and they're it's, again, I have no commercial stake. Anyway, okay. So I want to talk a little bit today about what's happening in training for psychedelics in general. A little bit of a step back and a broad overview about that and how that relates to training to work with ketamine. I want to start there. And then I'm going to talk about different approaches to working with ketamine treatment. And I'm going to add something new. I want to focus on the frequency, how often you need to provide ketamine treatment to your client, depending on which paradigm or which dosing strategy or which approach you're utilizing. So you may have heard part of that talk before, but try to listen again because there's going to be a new element in there. Also, my students tell me that they get a lot out of hearing the talks more than once. I'm also going to go over the clinical indications for ketamine treatment according to the research literature. That's the established indications that are well supported in the literature and some investigational ones that we're still looking at. Then I'm going to talk about the legal status of working with ketamine and the fact that there are different agencies that have different opinions about working with ketamine and how that impacts your legal safety. We'll talk about that. If there's time after all of that, I might want to talk a little bit about S-ketamine and about our FDA approval project, and then we'll end with questions. We'll do a live Q&A at the end. You can put your questions in the chat and we'll circle back to those. So that's what I have planned for today. So let's go there. Let's talk about training with respect to psychedelics. Obviously, there's a tremendous demand for treatment with psychedelic medicines. A lot of clinicians who want to be trained. The problem, as I see it, is that currently what's largely available is trainings that focus on one specific medicine. You can train in ketamine over here. You can train in MDMA over here. But you can train in psilocybin over here, etc. And the problem is that these trainings are highly redundant. They're highly repetitive. And that's not a good thing. It's a problem in terms of time, and it's a problem in terms of cost. And so what I'd like to propose instead is that we think about an octopus model for psychedelic training, where we identify what is the core teaching or the essential training that has to do with working with a psychedelic medicine or an altered state of consciousness that's common to all the different medicines. That would be the body of the octopus. That would be the parts of the training that would be in common. And then the legs of the octopus would be trainings that are specific to individual medicines. In other words, we could have training that first was an intro to psychedelics and working with these kinds of patients. And then people could choose optionally if they want ketamine training or MDMA training or psilocybin training or all of the above, et cetera. But in the form of, as I said, in the form of modules. That would be so much more efficient. In order to get there, we're going to have some standards for training. So far, these standards are non-existent, with the prominent exception of MAPS, who's doing a great job with standards. I have more to say about that. But another challenge that we encounter here is that it's very financially rewarding for individual organizations to offer their training and to not share information to other organizations. So at the moment, in the short term, the financial incentives are orthogonal, working in opposite direction to cooperative efforts. And this is really a problem that needs to be spoken to. So one thing that needs to happen, let me talk a little bit about solutions. One thing that needs to happen is I'd love to see a retreat for trainers from different pockets or trainers from different lineages to come together. I'm just giving you my ideas. I hope somebody will help implement it. We need some sort of a retreat for brainstorming and for creating cooperative efforts. And then we're going to need some sort of overarching organization that's going to help facilitate these conversations. And again, encourage cooperation among different agencies and groups. We're going to need some training standards, and then ultimately that's going to feed right into what I think is going to be a national curriculum for all mental health professionals, as I said, at the graduate level. So I think that's where all of this is going to go, and the question is how to get there. We have a couple of obstacles, a couple of challenges. One challenge is, how do you train people from different backgrounds? We have a cluster of people who want to be trained who are medical professionals, but who may not have skills to provide psychotherapy or do mental health diagnoses. Over here, we have mental health professionals who may not be qualified to assess or treat a medical emergency should one occur. And then over here, we have people who have been working in the psychedelic underground, who are very knowledgeable about these states, but who, again, don't have the medical skills nor the psychological skills to a large degree. And so what do we do about that? And it raises a question of, do we need to have different kinds of providers in the room at any given time with patients? That's going to be logistically and financially too difficult. And so then we get to this question of, how do you cross-train people? And is it possible to do that in an ethical way? What's the minimum that people need to know in order to do a job that they are not, didn't have a lot of formal education on? I have a lot to say about this, but ultimately, here's what I think is going to happen. I think where we're going with all this is, we're going to have different levels of training or different levels of certification. Sort of akin to someone who is a wilderness survival guide versus someone who's an ER doc. They both, have at least the minimum skills to, I'm sorry, what? To manage an emergency, but different levels of training. And so,
Oh, geez, I can't hear anything. Oh, I just went back to mute. Oh,
perfect time to get some water. Anyway, where I really wanted to go with this, and I'm trying to be brief here, but where I wanted to go with this is the idea of having different kinds of training and different levels of certification. And that always leads me right into a really important idea, which is, when we talk about psychedelics, when we talk about anything, we need to make a verbal and semantic distinction between what is optimal treatment versus acceptable care. Optimal versus acceptable. So optimal means, when I talk about it, optimal means the highest level of care that we could possibly provide, that is thoughtful and safe and ethical. And acceptable means, in essence, making concessions to reality. It means compromise. Acceptable always reminds me of that game that's played sometimes in junior high. Do you remember the game Limbo, where there's these bars and then they take the bar and they lower it and you have to pass underneath? And in that, when you play this game, the question is, how low can you go? And I think we're playing professional limbo to some degree with these questions about care. How low can we go that's still safe in terms of standards of care for our psychedelic clients? Anyway, all that to say that the purpose of CREA, the organization that I run, is to discover and describe what optimal care looks like with respect to ketamine treatment. And we have to make concessions to reality. The system that we're in does not allow for everybody to have access to optimal care all the time. That's egregious, but that's a bigger problem than one that I can address. And so we have to start thinking about what acceptable care looks like with respect to ketamine, but keeping in mind that that's not necessarily optimal care. So anyway, I wanted to just put that in the back of your mind for you to think about that. I want to talk a little bit about ketamine training specifically. We could probably use the same model for any psychedelic, actually, but for a comprehensive ketamine training, here's what it needs to look like. This is what you should be looking for. First of all, there needs to be some sort of assessment at the front end with entrance requirements as to who can receive the training or who's ready to jump in at that level. And then there needs, as I said, there needs to be some sort of introduction to psychedelics, introduction to psychedelics 101 that covers the basic principles of being with people who are having a non-ordinary experience. There needs to be, and let's get that out of the way, then that could be applied to multiple medicines, or could be, it's relevant to more than just ketamine. People who want to be competent with ketamine will need to engage in a guided reading. And actually, I have a reading list. Renee, if you can put that up, that'd be great. Guided reading on classic articles in this field is a good starting place. That's a good starting place, but not enough. There needs to be a didactic component where information is conveyed, usually verbally, and people have a chance to listen and get training and learn from other people's experience in that way. To be followed by patient observation. So there's a lot of ways to do that. You can do it with videos, you can do it with one-way mirrors, you can do it with live co-sitting, but what you want is to be able to see what the treatment actually looks like when it works and all the phases of treatment. To be followed by role playing or where students are working with each other to practice these skills, but before they work with real patients. To be followed by personal experience, that would be optional. To be followed by supervised cases, so where trainees are now working with real patients. And I would like to see those cases be low fee. I think there should be a mandatory requirement that everyone sees at least 3 patients for a full treatment at low fee all the way through to build their skills and to be closely supervised. Then after that, students would be, or trainees would be eligible for certification. And that would require another assessment point that they demonstrate that they have mastery in these skills. Built into that, there has to be a remediation program so that if someone isn't meeting the requirements or isn't satisfactorily demonstrating mastery, that there's a chance to fix that. There has to be a complaint board where the organization the certificating body can receive complaints about clinicians who are not providing good quality services. And then beyond that, there would be advanced topics and continuing education and more clinical experience. And in my opinion, you need to have all of that to be competent, and also all of that to call yourself a trainer. This is a huge problem. I can't tell you how upsetting it is to see people who, have a few personal experiences and then hang out a shingle as a trainer and are charging exorbitant amounts of money. I guess what I always say about that is having a root canal doesn't make you a dentist. And I think the same is true here. I'm probably preaching to the choir, but it's very concerning. We need to have written standards in place that we can implement. I guess the only other thing I wanted to say about this is that I'm getting some pushback in the medical schools about the idea of having experiential training with respect to ketamine or psychedelic medicine in general. And the reason the pushback is they say, well, we prescribe psychiatric medication all the time. We're not required to take it. And okay, that's true. But ketamine and these psychedelic medicines, as you know, are an experience more than they are a pharmaceutical. They're an experience. And as an experiential medicine, it's in a different category than other kinds of psychiatric medication, obviously. And it just seems to me that it would be hard to teach someone how to ski if you had never tried it. There are certain things that you just need to know from the inside, that you need to know in an experiential way, where the information isn't intellectualized or necessarily all verbal, but rather experiential. And so as we think about training more providers, again, I think you're sympathetic to my point. We think about these psychedelic medicines as these powerful and profound and acute experiences. And so because we're thinking about these medicines in a new way, I think we need to think about training in a new way. So anyway, that's what I've got on that. I'm really hoping for cooperation so that we can streamline this and make it more efficient and make the training more accessible. Okay, let's move on. I want to now talk about ketamine. I think that's what you showed up to hear about. As you probably know, ketamine was developed as a surgical anesthetic for humans in the 60s. We no longer refer to it in that way. It's better categorized as a glutamate modulator because it's primarily active in the glutamate pathway. And ketamine is really one of the first or one of the early medicines, but there's a whole slew of other glutamate modulators in the development pipeline. But I think it's better to move it away from anesthesia because the intent is not to use it as an anesthetic. So you know that it has rapid acting antidepressant and anti-obsessional properties, and it's up to 70% effective or helpful to about 70% of people who are truly a good candidate for this medicine. And those people are folks who have primary organic mood disorders. You probably know that it is highly dissociative and psychedelic in a particular dose range. We'll talk about that. It's broadly available. It's on the WHO's list of 100 most essential medicines and broadly available around the world. The best part of it is that it's dirt cheap. Generic or racemic ketamine is, pennies as a medical supply. So again, available and cheap. I like that. And the important thing to know about it is that it's really flexible. It's a tool that can be used in a lot of different ways at different points in treatments with different routes of administration and different dosing strategies. And it's worth knowing about a variety of approaches with ketamine because it has so many uses. And so that's what we're going to talk about today. So with every ketamine treatment, there are 4 essential steps to the arc of the treatment. And here's what those steps are. In all ketamine treatment, number 1, there's patient selection, which involves assessing the patient and coming up with a treatment plan. But first of all, seeing if the patient is appropriate to ketamine treatment and whether it's likely to be helpful for them. Patient selection, number 1. The next one is if the patient is a good candidate for ketamine treatment. Then the second step would be patient preparation. And that involves largely psychological preparation for these kinds of experiences, helping them make the most out of this and be ready for it. After you've completed that and you've formed a relationship with the patient and the patient is prepared and you've done all the consents and what I mean is informed consent, etc. Then the next step would be the ketamine administration. As I said, there's a lot of different ways that could look. And then the 4th essential step is follow-up care, integration, making use of the information from that session. And it's just such a simple model: patient selection, patient preparation, administration, and integration. And I'll tell you, I get so many unsolicited complaints from patients who have had difficult experience. And I get so many questions from clinicians. And so the first thing I do with them is ask, well, how did you manage each of these 4 steps? And 9 times out of 10, one or more steps was skipped entirely. That's a problem. So again, if you just use this simple model and conceptualize every treatment in these 4 simple steps, I think that's going to improve clinical outcomes and safety for sure. Okay, next. So as a clinician, there are 5 variables in ketamine treatment. That means there are 5 things that you can manipulate or modulate or control to suit your patient's individual needs. 5 things. Okay, and here's what they are. The variables in ketamine treatment are, number 1, the route. How are you choosing to put the ketamine medicine into the patient's body? Number 1. Number 2, the dose. How much ketamine are you choosing to put into the patient's body in a single session, and why? Next variable, number 3, is the frequency. How often are you proposing to do this, and why? And I'm actually going to be focusing on that today in my talk because this is really an important point. The next variable, I said there was 5. The next one is the physical setting. So we all know that the physical setting is actually really important when using visionary medicines. But in traditional Western medicine, this variable is often overlooked. And people have this crazy idea that it's a good idea to give ketamine in an ER amidst noise and chaos and stuff. And that actually does not lead to optimal outcomes. So setting is the next one. And the last variable in ketamine treatment is clinical presence. That means the person or the people who are providing ketamine, how do they understand their job while the ketamine is being administered? What exactly are they doing in the room? do they have the patient on a baby monitor and are they in a separate room and leaving the patient alone? Is that, and they're focusing on using technology to monitor the patient's vitals? Okay. Are they in the room giving psychotherapy? Are they in the room as a unobtrusive sitter who is radiating loving presence? In truth, in clinical practice, we actually do a blend of things. We are providing medical monitoring. If we're psychotherapists, we may do some therapy. There are times when we need to sit back and quietly observe. But it's important to be able to think through what you're doing and why in any given moment, and how you would articulate that role. It's okay if you move fluidly back and forth between different roles, but it's important and some people don't have the skills to do certain things. If you don't know how to do medical monitoring, you wouldn't be doing that, etc. But it's just something that we need to be talking about and thinking about. Okay. And I wanted to say one other thing here about the routes. I did mention that there's different ways of getting ketamine into people's bodies. I'm not going to go into detail about that right here. You can ask me about it later if you like. But I do want to point out one critical thing, which is that different routes of administration have different bioavailabilities. So bioavailability refers to the amount of medicine that makes it to the target organ to do the job that it was intended to do, and the rest is lost through metabolism. It's like it's moved through the body and excreted away. And it's critical that you understand that ketamine infusion put into a vein, or ketamine injection, so injected into a muscle, have very high bioavailability, 97 and 93% respectively, I think, meaning that most of the medicine that is administered makes it to the brain, makes it to the central nervous system, and does the thing that you want it to do. But I guess I am going to talk about this. Here's the thing that you need to know is that when you move to nasal administration, like nasal spray, or lozenges, which are pieces of candy that have medicine compounded or put into it, the bioavailability drops precipitously to less than 50%. So less than half the medicine that you're administering is actually making it to the patient's brain. And the amount that actually makes it to the patient's brain is highly variable. It varies from patient to patient and day to day and hour to hour. And this is highly undesirable for clinical treatment. For example, the lozenges, these candies that I was talking about, they're called transbuccal lozenges, and they're absorbed. The person puts the candy or the lozenge in their mouth and holds it between their gum and their cheek, because that's where the absorption is best. And so holds it for 15 minutes or something. And we very loosely estimate this, the bioavailability. We very, very loosely estimate that 40% of the amount of medication that was administered actually makes its way to the brain, because it's inefficient. But but in reality, it's actually been clocked as low as 20%, 25%, and as high as 60%. And so you have really no idea how much medicine is making it to the patient's brain. And that's a problem, a huge problem. So for that reason, we like injectable ketamine better, because it's so much more precise and also has a more rapid onset. But that, of course, requires that there's a medical professional in the house. I could say more about that. I think you get the idea. I guess the other thing I want to say about this actually is that if you are a therapist and the patient tells you that they were getting 100 milligrams in infusion, it's not the same to give them 100 milligrams in lozenges. You have to do the math. You have to do the conversion, utilizing that bioavailability information in order to get an equivalent dose. So there's a lot to know about this. It's kind of a technical point. Okay, let me move on. So I have now articulated for you 5 different variables in ketamine treatment. And I want to go over a couple of different approaches to working with ketamine. And I want you to listen for these variables, how different approaches use this tool in a different way. So the first approach that I want to talk about is something called the research protocol. the research protocol for ketamine. And the vast majority of the early research on ketamine treatment for depression was done using this protocol. That's why it has that name. And so here we go. In the research protocol, the patient who has severe and refractory depression is administered 0.5 milligrams of ketamine per kilogram of body weight of ketamine, of racemic generic ketamine, the cheap kind, in an infusion that usually lasts about 40 minutes. There's nothing magical about the 40 minutes. They did that so that they could change patients on the hour. It could be shorter, it could be longer, as needed. But here's the thing. The reality is that 0.5 mg/kg, the researchers chose this dosing strategy explicitly because they thought that psychedelic experience was a problem. They thought it was an undesirable side effect that should be avoided or medicated or managed. And in the literature, they refer to this, any kind of psychedelic experience that the patient has, any kind of psychospiritual insight or any joy. They refer to that as psychotomimetic in the literature, meaning that the researchers categorized the patient's experience as mimicking psychosis, which is, of course, a complete misunderstanding of psychedelic experience and a misunderstanding of psychosis also. But anyway, I say that because in the research protocol, the researchers are trying on purpose to avoid psychedelic experience by dosing under it, by giving too little to create psychedelic experience. Okay, we understand that. Problem, the dose is not particularly potent or durable. It doesn't really work all that well. And so to get around this problem, the way that they solved this problem was by creating a cumulative series. So you've probably heard that lots of patients are advised to get 6 ketamine treatments in the course of 2 or 3 weeks. And the idea there is to give a total amount of ketamine that's going to do the magic thing that ketamine does. Excuse me this morning. You want to get a certain amount of ketamine into the patient, but in divided doses, such that in any individual session, it's not too psychedelic, not too sparkly. And so I need for you to understand that the reasoning behind having 6 sessions and having them close together is predicated on, is based on the fact that the dose is too low. And one of the critical mistakes that contemporary ketamine therapists are making is that they are using this model erroneously to argue for ketamine therapy or a psychedelic ketamine at that frequency, and that's not right. This dosing strategy is meant to be cumulative. In other words, you give a low dose session, and then before the effect fully blossoms, you give another one to add on. And before that effect fully blossoms, you give another one to add on. And so it's a cumulative series of divided doses. I hope that makes sense. Anyway, all right. What else did I want to say about this? Patients have a whole variety of experiences. It's not uncommon for them to say that this feels a lot like drinking 2 glasses of wine on an empty stomach. So whatever that means for you, it's not fully dissociative. The patients can open their eyes, they can go to the bathroom, they're ambulatory. If you talk to them during these infusions, they most certainly, for the most part, they know who they are, they know where they are, they know what's happening to them, and they can articulate that. So this is, by definition and by design, not a fully dissociative or psychedelic dose. This is sub-psychedelic dosing, sub-psychedelic. Okay, and this is, so here there's no psychotherapy. That's the other important point. There's no concurrent psychotherapy that is required or even recommended often. So this is basically a medical or a surgical model at heart, where the medicine is doing all the work. The medicine is the healing agent, and the patient is a passive recipient of the medicine. And this medicine is conceptualized as doing something magical at the level of something molecular or basic biochemistry, at the level of neurons and receptor sites. So really, kind of like the micro view, like at the cellular level, I guess. And again, I just want to say again that there's no psychotherapy necessarily in this model. The psychedelic properties of ketamine are considered a problem. And yeah. So again, it's important to really understand this model because so much of the published literature utilizes this model. So you have to understand what you're reading and what the inherent biases are. And in truth, we actually do send people sometimes for this kind of treatment. It's ideal for patients who are medically complicated or patients who need a higher level of medical monitoring or care. If the patient has physical pain and needs to be treated with ketamine and other medications together, this would be a great approach for that. So we have partners in our community that we refer to as needed. But the challenges here, there's two challenges. Problem number one is that the patient is in a passive position. The patient isn't called upon to do anything, to participate at all in their own treatment, except to show up for the appointment. And while that's a perfectly good approach for, like an appendectomy, the question is that an optimal approach for a chronic mental health problem? And I don't think that it is. So that's problem number one. Problem number two is that the effect is temporary. The biochemical effect wears off very quickly, depending on the dose. So we'll talk about that. But the problem is that you basically turn the patient into, you make them dependent on ketamine, or worst case scenario, you turn them into a ketamine addict. Because if you're not teaching the patient any skills to help themselves, then the patient essentially becomes dependent on ketamine forever. And if you're selling an expensive ketamine product or ketamine service, then this is good for you as a provider. But with respect to what's good for the patient, I don't know that this is. So we can debate that a little bit later. Just to say that the S-ketamine product now, the nasal spray, they designed that protocol. It's designed directly. It's based off of what I just said, this ketamine infusion model. So with the same biases, the same assumptions, and the same limitations. Okay, let's move on. I want to talk now about a different way of using ketamine. It's the same medicine, but a completely different approach. Yeah, okay. So the next thing I want to talk about is using ketamine in ketamine-facilitated psychotherapy. In other words, using ketamine as a catalyst or a lubricant for the psychotherapy process, where the psychotherapy is front and center. The psychotherapy is central, okay? So it's different from the previous one where there was no therapy. Here, the emphasis is on the therapy dialogue. So for ketamine-facilitated psychotherapy, you might do this with injection, like a lower dose injection, or lozenges if that's what's available. And you would do this in the context of an ongoing psychotherapy relationship. Okay. The thing is that you wouldn't do this very frequently. You would do this, once every couple weeks is a good pace for this. It is possible to do one ketamine facilitated therapy session per week for like 3 weeks, like to do a little contained series, but you wouldn't do that ongoing. You would, mostly people need time in between the sessions to process the information and make use of it. So spreading it out is important, making it spacious. And so again, depending on the dose, this usually takes about 2.5 hours. And typically what you see is that patients sort of naturally and organically return to material that they were talking about with you in regular unmedicated psychotherapy, but they revisit it and they have a new take on it, or it lands in a different way. Sometimes it consolidates, like it just sort of seems like it all comes together and sort of the knowing becomes embodied. Not a good time to go digging for new material. So here, as I said, the emphasis is on psychotherapy. I would add that, of course, this is very closely related to what MAPS is doing with MDMA. Anyway, here, this is essentially a psychotherapeutic model The psychotherapy is central. It's still usually done in a sub-psychedelic dose, so below the full psychedelic range. If you give the patient too much medicine, they can't reflect or engage with you in a meaningful way. Worst case scenario, if you give them a full psychedelic dose, they forget that they have a mouth and they don't want to talk to you. So that's not, that doesn't work well for psychotherapy. I'm kind of kidding, I'm kind of not. But anyway, here, what I really wanted to say is that the emphasis here is on the verbal metabolism of difficult material. So this is ideal, of course, for patients who would benefit from psychological work and who are able to make use of psychotherapy. The problem here is that psychotherapy is expensive as we think of it now, and it takes a lot of time. And so there's a financial and logistical bottleneck, I think, that needs to be addressed in some way. I have some ideas about that. And not everybody likes to talk about themselves, so they should have other options. That's okay too. Here, I want to make a distinction, an important distinction, which is there's a difference between, well, originally when we were first talking about this, experienced psychotherapists were dropping an occasional ketamine session into an ongoing depth-oriented psychotherapy process. So there was really this big container of psychotherapy with just the occasional ketamine treatment, and that gives remarkable results, I have to say, having seen it myself. But it's important to distinguish that from the other phenomenon, which is where the patient shows up and wants ketamine treatment with a therapist they don't know. So they're showing up and they're having ketamine in a compressed form in a short-term therapy. It's hard to really call that therapy, because I think that part of therapy, what makes it work, is that there's a lot of familiarity between both people. There's love and trust between them. And in a short-term format, it's just hard for that. There just isn't time for that to develop. So I think we need to start making a very clear semantic distinction between ketamine that occurs in a depth-oriented psychotherapy process versus doing ketamine or having a ketamine session with a psychotherapist in the room, and what could we call that would make it more clear what that is. But there's no doubt in my mind that they give different clinical outcomes. And so that's going to have to be parsed out in the research as we go forward. I think I already hinted at the fact that using ketamine combined with psychotherapy can be very potent because learning is enhanced in that window immediately following ketamine exposure. And we don't know exactly how long that window is, but it looks like it's going to be 2.5 days, more or less. And actually, very specific kinds of learning are amplified. So not all learning is amplified, but relational learning and emotional learning seem particularly, people seem very receptive to learning at that level. So I think there's something there that we need to understand better. And I think that there is a biological process that underlies this, or that correlates with what we see clinically, which has to do with, I'm not very good at explaining it, but when you put in ketamine into a human mammal, it sets off a chemical cascade that leads to ultimately to the synthesis of new proteins that leads ultimately to dendritic sprouting. That means the tips of the neurons pop out and they go like this and forms new neural connections. And my best guess, I feel pretty confident in saying that that process, which can be observed under electron microscope, must be the physical correlate of what it is that we actually see clinically, what we can observe. So I think there's something there. I'm going to leave it to the neuroscientists to continue that research. But anyway, what I wanted to say is that from my perspective, the goal of ketamine treatment is to help patients develop skills as much as possible, such that they can enjoy their lives and do as much as they can on their own. And specifically to help develop new social skills and emotional regulation skills, and with the idea that they wouldn't be dependent on medication forever. So certainly some patients do need medication forever, and they absolutely should have that. No question. But the vast majority of people are probably over-medicated, and this might be a way to address that problem. Okay. I spent more time on that than I thought I would, but that's okay. All right, let's change paradigms. Okay, I think we covered that adequately. Let's move on here. Let's talk now about psychedelic ketamine journeys. So I want to just emphasize that the previous two things that I've described to you are sub-psychedelic, not psychedelic, under psychedelic by design, on purpose. And so really, one of my pet peeves is when people talk about ketamine only as a psychedelic medicine. That's not true. You've misunderstood or missed 2/3 of what the treatment is about. It's actually not psychedelic, or the treatment is not psychedelic on purpose. But here we come to the part where it is psychedelic. So for some folks, using ketamine to invite or induce a mystical experience on purpose, that's where it's at. In other words, we're using ketamine and its anesthetic and psychedelic properties to put the patient into pre-anesthesia, essentially, and quiet sensory input such that their consciousness or imagination or spirit or whatever you want to call it is free and has an expansive experience. So this is most often done with injection. I am not a fan of doing this with lozenges, but you do what you need to do. And so usually patients are given about, we usually consider the psychedelic dose range begins at 1.0 milligrams per kilogram of body weight. So if you have a 150-pound adult, psychedelic dose range starts at 68 milligrams because the patient weighs 68 kilograms. And so this is often done between 1.0 and 1.5 mg/kg. I personally think that the sweet spot for treating organic depression is 1.25, 1.25 milligrams per kilogram of body weight. And I'm waiting for the research to validate that, but that's what I think. Let me just take a quick look here and make sure we're all good. Okay. And I was going to say something else about this. Okay. So here's the thing. You would only want to do this occasionally. Some patients do well having this like once a year. Other patients benefit from having it once a quarter. But not something that you would do like often. People need time to prepare for this. They need time to integrate from it, make use of the information. Some patients need it once a month, but that's quite rare. And so if you're doing it more than that, I think there's a problem. I think there's something else going on. I was going to add that for an individual session, we may keep the patient with us for 4 hours. For group work, it takes all day. We usually have people with us for 6 hours or more. And what happens is that you give the patient, this is after the patient has been selected and prepared. Okay, now we're jumping ahead to step 3, medicine administration. The patient, you do your check-in, you get all set up. The patient receives a shot of ketamine from the medical professional, and very rapidly, within a couple of minutes, they are immobilized and in a state of full dissociation, so loss of awareness of their own body, and they are launched into a state that has colorful, dream-like visions that lasts about an hour, maybe hour 15, to be followed by a couple of hours of sedated recovery. I highly suggest that you try this if it's legal for you to do that, because it really is ineffable and indescribable, but I'm doing my best. So this is essentially a shamanic or a psychedelic paradigm at its core, because here the emphasis is on the healing potential of the visions. So we're not trying to avoid the visions, but rather we're focusing on the visions and the messages that are imparted. The visions are central and essential. And I want to clarify that you would do this in the context of psychotherapy, with ideally with therapy before and after active medicine. But you're not actually doing psychotherapy, at least we don't do psychotherapy, while the patient is actually having active visions. They're not really receptive to that. So The therapy is before and after. So anyway, this kind of work is ideal for people who have an interest in psychedelic medicine, preferably folks who have explored their own minds in some form or another, either with other substances, like legal ones, or with meditation, but have some sense of the relationship between observing thoughts and then the visuals. I want to add that this is actually not psychologically safe for lots of clients. And I have grave concerns about people doing this on their own because of the negative and adverse events that I'm aware of. And so just to say that working with ketamine, the risk of something adverse happening goes up as the dose goes up. And so you want to be really thoughtful and careful about when you do this and why, and selecting people appropriately for this style of work. Okay. Do I have anything else I want to say about that? No, I think I'm good. Let me talk for a second about integration, and particularly integrating from psychedelic experience. You probably know a lot about this topic already, but just to say that when I'm conceptualizing integration, I love to count on my fingers. I'm thinking about 5 different levels, so 5 different things that I'm going to make sure that I ask about in the therapy that follows. And so for me, the 5 levels of integration are body awareness. What did you notice in the experience of your body? Number 1. Number 2, behavioral. Did you get an idea of something that you could do differently in your everyday unmedicated daily life to move yourself toward wellness? So something action-oriented. Behavioral. The next one is psychological. What did you notice? What messages did you get? What are you thinking in your relationship with yourself and your thoughts and feelings? That might be internal. 3. 4, I want to talk about interpersonal relating. So what happens between you and other people, either in your family or in your community or in your sense of tribe and belonging, but in between people. I'm sorry, I don't know why I have a dry throat today. Excuse me for 1 second. Must be all that nice spring pollen that has found its way to me. Let's see, I said there was 5 things. I got 4, and the 5th one is spiritual. What's happening in your relationship with God or the sacred or the divine? Another way of saying that is, what did you notice about your own consciousness? Whatever words the patient prefers to use, but something that is transpersonal. Anyway, all of this takes time, and these are the things that I'm going to be asking about in the integration sessions. And then sort of seeing where the juice is. Okay, so we had talked a little bit about frequency, and I want to bring that up again. I want to start by saying this. When the dose is optimal for ketamine treatment, and that number is different for everyone, treatment looks different for different people. When the dose is optimal, when the patient got what they needed, and we've done a good job of matching the ketamine treatment to the patient, the biochemical effect, the effect at a chemical level, the physiological sort of uplift, lasts about 2 weeks, about 14 days on average. And usually patients experience that as the first week being more prominent or more pronounced, and the second week it's more like a subtle tail. But at least they should get 2 weeks of lift. And for people with primary organic depression, very specific population. And so when people want or need to do ketamine more frequently than that, that's a sign that something is not right. Either the dose wasn't right, or the setting wasn't right, or the preparation was inadequate, or the physician is prescribing inappropriately, that maybe they don't know better, that happens a lot, or the physician has a conflict of interest where they benefit financially from a different arrangement. And I think we need to get really honest and suspicious of that. And particularly when individuals are telling me that they are self-treating legally, illegally, whatever, I don't know, and they're doing it, more than once every 2 weeks, more than twice a month. Okay, that's not consistent with what the research literature says. So I don't think that can be justified. I think that's a problem. So there we are. And then we also talked about the cumulative series. So when you do the low dose ketamine infusions and you do 6 stacked together in this very particular structured protocol, that may actually lead to several months of chemical or relief at a chemical level. I've seen that. And then patients usually remit unless you've put in other interventions to support them. Here's the interesting part. We've been tracking patients now since 2014. And for our low fee patients that we had in the very beginning, we continue to make services available to them very low fee. So the fee is not the issue, I don't think. But we have patients, now going back to that cohort, who indicate that they got what they needed from their ketamine explorations or treatment, and that they don't want or need anymore. Or some of them need an occasional ketamine booster. But here's the interesting part, is when people talk about the fact that their ketamine experience, usually psychedelic experience, sometimes ketamine facilitated psychotherapy, they're separate things. They sometimes say that those experiences were some of the most impactful and most meaningful experiences of their entire lives. And that some of them say that they continue to benefit from the effect of those experiences above and beyond the original biochemical lift. In other words, that there may be a psychological benefit, psychological relief, or psychospiritual change, or information, or learning, or process that continues to benefit them far beyond when the chemical effect wears off. And I think this is fascinating. And the problem is that the research, the quantitative scientific research literature, has done a very poor job of capturing this phenomenon to date, for a couple of reasons, for good reasons. Number one, longitudinal studies are hard to do, and they're expensive, and they're confounded because real life happens. And so it's hard to isolate what exactly, contributed to what. But I do think that science needs to pay more attention to this phenomenon because we're seeing it more and more and more. And if you talk to a lot of ketamine providers, I think you'll hear the same thing. So it just raises this really interesting question, which is, how do we make sense of this? This is different than how we understand most psychiatric medication. How do you understand, how do you talk about, how do you measure treatment that extends a benefit far beyond the biological effect? What happens if the benefit spans months or years? And in some cases, I'm not kidding, decades. I'll give you an example from my own life. I remember vividly the first ketamine experience I ever had back in 2002. And that original vision 20 years later still informs the way that I lead my life and my professional aspirations and some of the choices that I make. So that one vision, that first one, I remember it like it was yesterday, is continuing to inform me 20 years out. Okay, what do we do with that from a research perspective? So anyway, I just wanted to throw that out there for you to think about. Okay, let me summarize what we've said so far, and then we'll check in on the time. So first I talked a little bit about psychedelic training in general and the need for us to come together and cross-pollinate. And I talked a little bit about different components of a training program. And then I moved over to talking about ketamine and different variables in ketamine treatment. And then I outlined for you 3 different approaches to working with ketamine in your clinical practice. So the first approach that I talked about was using ketamine as a pharmaceutical intervention. So really focusing on what it does at a biological level. Then I talked about using ketamine as a lubricant for psychotherapy. And then I talked about using ketamine as a psychedelic agent with an emphasis on producing psychedelic visions. So you've probably heard me say this before, but it's worth repeating. Which of these treatments is the most effective? As a provider, what should I provide? As a client, which of these services should I seek? And the answer is that different things work well for different people, and that all of these services should be available. And the competent ketamine provider, from my perspective, is knowledgeable, at least has a working knowledge of this entire spectrum of ketamine services. I'm going to get a throat lozenge in a second. But just to say that the competent ketamine provider, the ethical ketamine provider, really is not married to any one specific approach with ketamine, but rather understands the fact that there are different routes of administration and different dosing strategies, and those different dosing strategies correlate with different frequencies, and that all of these are valid some of the time, and that some people are helped by these different strategies at different points, and none of them work well all the time. None of them are appropriate all the time. So one more time, the competent ketamine provider understands that there's a spectrum of ketamine services and learns how to match the treatment to the patient. Renee, will you put the training link up for me again? And I'm going to suggest that we take like a 1-minute break because I want to get a throat lozenge because I seem to be coughing a lot today. And then Dr. St. Gore, we'll see where you want to go from here. I've got some more stuff, or I'd love some feedback.
Yeah, no, first take care of yourself. This has been amazing and we want you to feel better.
I don't know what's going on with me today. Excuse me for one quick second. I will be right back.
Fine.
Yeah, take whatever time you need, Raquel.
What does it say for timing for people covered?
Training. What? No, people keep leaving, so then we have.
I'm back. I don't know if you can see that. Raquel saves the day.
Thank you, Raquel.
So how would you like to use our remaining time?
So we have some good questions in the chat. So let me start with those. Does that sound okay to you?
Well, I was going to say that I'm about halfway through the lecture that I had planned, so I can continue if you want, or we can switch to questions as you wish.
Maybe could you do 10 more minutes and then we have 20 minutes for Q&A? Does that work for you? Or
I'm looking at the time.
Yeah.
It's up to you. Well, okay, you tell me what would be most interesting. We can talk about the established uses for ketamine.
Okay.
We can talk about the legal status of ketamine. We can talk about S-ketamine. Those are some of the things I was thinking about. It's not going to fit in 10 minutes, though.
No, any of those fit in 10 minutes? Though we also want to listen to you.
Up to you.
Could you do the legal in 10 minutes?
I'll try my best. Okay. Sure. So the legal issue, the legal issues relating to working with ketamine relate very intimately with what is in the scientific literature. And here's why. If you get called in front of the board, the way that clinicians defend themselves is by printing out and citing what's in the research literature. And if there is no literature that speaks to what you did, then that's basically not defensible. And so that's a problem. So let me say this in a different way. There's two different concepts that are related and overlapping that are important to understand here. The first one is what is considered legal. So in this country, Ketamine is in DEA Schedule 3. That means it has legitimate medical uses, can be used as per the clinician's best judgment. And if you violate this, you could if you do something that's not legal, you could potentially go to prison. But that's not where clinicians run into trouble. Clinicians run into trouble in a different spot, which is something that is not clinically or legally defensible. That means that if their case gets heard in a malpractice case at a regional level, locally, or if their case gets pulled in front of the board, the question is does the board agree with your decision-making process? And here's the catch. The fact that it's in DEA Schedule 3 is not enough to protect you. The board has to agree that what you did was clinically necessary and consistent with how other people practice, usually as evidenced in the literature. Anyway, all this to say is that what you can actually do as a clinician and still be safe with your license means that you have to take into account what the DEA says, what the FDA says, what the state board says, what your malpractice insurance will cover. This is often overlooked. And then, as I keep saying, all of this references what's happening in the research literature. And so if the board would not agree with you, you can't do it. A good rule of thumb here is if somebody asks you for something, and if you think about it like they were asking for an opioid, would you give it? And if you would, you're okay. And if you wouldn't, then that's a good guideline. So just to say that what's legal and what's legally defensible are actually not the same thing when it comes to ketamine treatment. A lot of clinicians don't understand that. Let me add to that. If a patient comes to you and wants psychedelic experience for the sake of psychedelic experience, there's no doubt in my mind that that might be beneficial for some folks, but it's probably not legally defensible because it's not in the literature yet. Okay. What do we do about this problem? What we do about this problem is you need to get more stuff into the literature. Let me just pull up a little, I'm looking at my outline. So one thing that you can do, there are a number of things that you can do right now to push the whole field forward. So one thing that you can do, here's some things. You can get more training to increase your skill level. You can partner with somebody in your community who has complementary skills. You can write up your cases and publish them. You can write up the things that you see a lot, which are considered clinical trends, like kind of what typically happens. You can also write up things that are unusual, like individual cases that where something went in a way that was surprising. And it can all be qualitative. You don't need to do statistical analysis if you don't want to. You don't have to quantify stuff. You can just describe it. And that's still publishable, and that still pushes the field forward. As long as I'm in the neighborhood on this, I'll add a few things. Another thing that you can do to push the field forward as a clinician is you can mentor or train other clinicians after you have a good amount of experience under your belt. Here, I'll try to bring this in for a close here as best I can. If you are a philanthropist, not a clinician, but wanting to help the cause through financial support, there is one thing that you could do that would be incredibly impactful, which is to help us to get FDA approval for generic ketamine for a mental health indication. So I'm working on this now in partnership with People Science. Belinda Tan, I think, might be here today. And the FDA approval is the missing link to getting broad medical insurance coverage for these services. So we really need it. And we've been volunteering our time. We're not paying ourselves anything, but we are going to need a couple $100,000 to get ourselves to the next step in the FDA approval process, and probably a couple $1 million to get across the finish line. But just in terms of impactfulness, this is like a steal relative to what was spent on some of the other projects to get FDA approvals, because in our case, we're only getting an additional indication added on to ketamine which already has FDA approval and anesthesia. So we're not starting from scratch. And so just to say that we think that there's 300 million people worldwide who suffer with depression, and probably a third of them are treatment resistant. And here with a couple $1 million, we have the opportunity to help a really huge number of people, and also to set a precedent for the use of a sacred medicine in a safe and legal context. So I hope some people will come forward to help us with that. Already underway. And let's see, I guess a couple of other things I wanted to say by way of closing. Yeah, I got 1 minute left. I'm gonna use it. I want to talk for a quick second about the ethical guidelines. Renee, if you can give me the link for that, that would be amazing. About 2 years ago, I authored a document. It's really brief, the ethical guidelines for ketamine clinicians, which describes very briefly and in a skeletal way how people could provide ketamine services in a way that's thoughtful and safe and ethical. And so please take a look at that. It was published in a medical journal in 2020. And it's important to know that this document, this one, is currently being used in inquiries to the board in many states and in multiple malpractice legal proceedings. And so as a clinician, if you're doing something, well, what I want to say is that this is the only document of its kind that addresses this with respect to ketamine treatment. And so if you're doing something that's not in alignment with these guidelines, that could potentially be a problem. This is the published standard of the community. So please have a look at that. Really important to know about that. I guess there is just like one other little thing I wanted to say before we take some questions, which is, actually, can I do a quick screen share? Let me see if I can get this up for you. Okay, let me just see how I don't know if I can do it easily, but I'm gonna try. I am gonna try. I wanna show you something that I just was working on because this is important. Okay, can you see that? Oh, that's not what I wanted. I want that.
We can see it.
Okay. I just want to show you, I just want to talk for a second about this question of whether ketamine can be used for patients for psychospiritual exploration who don't have an Axis 1 diagnosis, who don't have psychiatric symptoms that we're trying to manage. So just FYI, this is for an adult who weighs 150 pounds, just sort of like an average standard. If they were getting the infusion or the research protocol, they would get 34 milligrams of ketamine at a time. I'm going to skip the next one. If they needed light sedation for like a quick medical procedure, something not too painful, like getting some stitches, they might get 136 milligrams of ketamine. I'm going to skip one. If they were in horrible pain, maybe they were in some sort of terrible accident and they needed to be transported, lots of broken bones, they might get 200 plus milligrams of ketamine. You can see it right here on the screen.
Raquel, I'm so sorry. I don't think you're showing us the slide that you're describing. The slide I can see says pushing the field forward, clinicians.
Oh no, the slide that I want to show is, can you see that?
Yes, that looks much more like what you're describing. Thank you, and I'm sorry to interrupt.
Oh, I'm so glad you told me. I didn't know. I can see it on my end. Okay, here's the slide that I really want you to see. There, how's that? Better?
Yes, that's great. We got it.
Okay, great. I just want to show you something because it's just so interesting. The patient presents to the ER, they're agitated, they're violent, they may get darted with 500 milligrams of ketamine. And some patients have actually, a few patients have gotten ketamine coma with 3,000 milligrams of ketamine per day, obviously in a tightly supervised setting. And the part I didn't put here is that they actually get it for 5 days. So the grand total is 15,000 milligrams of ketamine. And all of this is considered safe in medicine. This is all sort of like standard practice in medicine. And so how are you going to tell me that somehow it's not safe to give the same patient, particularly a healthy one, that relatively speaking, that they shouldn't get 68 milligrams of ketamine for personal exploration? The idea that it's not physically safe makes no sense, truly, if you just look at these numbers. The question of whether it's psychologically safe is a different question and one that we need to unpack carefully. But anyway, just to say that, when people make a fuss about psychedelic ketamine, I want them to see relatively where it falls on the scale of how ketamine is used on a day-to-day basis. Okay, I will stop my share on that. Let's see here. I think I'm just about done.
Great. Well, this is wonderful, Raquel. And I have to say in the chat, people are saying, don't stop her, don't stop her. I think we do have to do a few Q&A and we'll figure out how we can get more of you later. So let's start with questions and maybe we'll have a little more time. Just to update everyone, Rick is, as we're speaking, putting his recording into a Dropbox for us. So we have at least 15 more minutes, but we're going to have more time than that. So first question, Ron Miss, are there clinical treatment centers using ketamine to treat alcohol addiction?
Yeah, there are. Yes. A couple things to know about this. So the research on this goes back to a Russian researcher named Evgeny Krupitsky, someone that I know. And he got remarkable results, 20 yeyears ago, using psychedelic ketamine in combination with individual psychotherapy and medication management and group psychotherapy and psychedelic ketamine for people with severe alcohol addiction and later opioid addiction. But it was all in a contained environment, which is a polite way of saying that the patients were in a locked unit and had no access to, it wasn't outpatient. And so there's been this lingering question as to whether that could be replicated in outpatient treatment. Then came Elias Dakwar, and he has been combining ketamine treatment with mindfulness training to teach people to be more aware of their own internal process. And so he's had some success in an outpatient setting treating addiction. But you have to remember that his clients are seeking him out, or his subjects are very highly motivated. And so there's a question that I think is still unanswered about whether you could use ketamine to treat other kinds of addiction in a more varied population. And the answer is, I don't know. I think the research is changing on this, and I think it's worth watching. But I would start by taking a look at what those two researchers wrote. By the way, can we put the reading list back up? I have a curated reading list where this information is organized by topic. It's free, so you're welcome to make use of it. I also wanted to mention on my website, I have tons of other free stuff for clinicians, not just the reading list, but clinical scales and clinical guidance and music and all kinds of stuff. And so please take a look. I put it all there for free for you. So please avail yourself to it. Okay.
That's great. Thank you.
Thank you.
So Tyler Agersey, I hope I'm pronouncing your last name right. Could you ask your question, please, Tyler? Tyler? I can read what he wrote, but he was going to elaborate a little bit. So he wrote, I agree that 0.5 mg per kg is too low, but for any patient with comorbid substance abuse, 1.0 mg per kg is a bit high and can provoke mood. I can elaborate why, but I'm interested in hearing more about the distinction between these two doses and also the 1.25 mg kg sweet spot mentioned.
Oh yeah, thank you for the question. So as I was wanting to say earlier, 1.25 mg kg, I think, is the sweet spot for a patient who has refractory primary organic depression. That's their presentation. In other words, that their depressive symptoms are best understood as something probably hereditary, probably body heavy, probably started early in their life. And the dead giveaway is patients whose their mood changes for no reason. Often they have diurnal cycling or diurnal variation, where they feel a little better and brighter at the end of the day. And then they wake up in the morning, they sleep, they wake up in the morning and they feel god awful, and nothing has changed. There's been no change in external circumstances, no new stressors. So patients who look like that probably are having a biological or neurological problem, and it has a very specific flavor to it. And those folks sometimes benefit from, and if they're appropriate to ketamine treatment, and they're appropriate to psychedelic ketamine. So there's a couple of layers of patient selection that we go through. Those folks, if you're going to go into the psychedelic range, I happen to think that 1.25 is often the dose that seems helpful. But you're asking about a completely different indication. You're talking about people with a substance use problem. Lots of different ways to conceptualize that. Substance use may be related to anxiety or trauma or depression or who knows what else. And so you've really got to do a great differential diagnosis to figure out what's going on here. How do I understand the nature of this person's suffering? And then come up with a treatment plan, which may or may not include ketamine. Side note on that, no doubt in my mind that MDMA is a superior tool for treating trauma. Sadly, it's not broadly available at this time. It's coming. And so some people try to work with trauma with ketamine, even though it's not ideally suited to that. So that's a treatment.
Can you hear me?
Yes.
Okay, I was trying to speak earlier, but I think I played with my inputs. So you were saying 1.25 specifically for the patients you were describing. Now, I specifically said what I said because I just wrote this paper on epigenetics, and so the main thing with addiction is a molecular switch called delta FOSB, which is a transcription factor that activates all these other downstream genes. But pretty much as soon as that is produced in sufficient quantities in the nucleus accumbens, the neurobiology of addiction is present. Now, Krebs is another thing that is integral in the steps to producing delta FOSB, and Krebs is elevated in people with depression, and that's probably a good reason why there's such high comorbidity between those two disorders. Now, when the therapeutic effect of SSRIs kick in, the Krebs is reduced, so there's no longer elevated levels of Krebs around. There's also less delta FOSB and other transcription factors that activate that pathway. The high dose in particular.
Let me cut in here because
97, now you'd be 98.
No.
that is what you're describing is complicated enough that it probably needs its own lecture in itself to really visualize and understand that. I want to go back to your earlier question about working with people with addiction. I have some reservations about that, and I do that very cautiously or very, very minimally, frankly. Working with addiction is a specialty, and so some people who are addiction therapists may choose to add ketamine services to their practices, but I don't know that that's something that I think should be done with caution. And I think the neurobiology of it is really interesting. And also I'm an anti-reductionist. That means that I actually believe that most mental phenomena cannot be understood through biology or chemistry alone. But maybe these things will converge in the future. I don't know. But anyway, all that to say, there's two schools of thought about this. I'll just summarize. Some clinicians think that it's not a good idea to use a pleasurable chemical in the treatment of other kinds of addictions. And other clinicians think that if you treat the underlying anxiety or depression, that might be helpful in treating addiction. And I'm not really in either camp. I think it should be decided on a case-by-case basis. So that's what I got on that. I
Well-
hope that's helpful.
Well, I was more so prodding for just more detail about as far as the distinction you make in your clinical practice between the 0.5 milligrams you start lower and then try to work up, or
No, yeah. So to get more into that,
Yeah,
the question of who's a good candidate for what is best covered in a comprehensive training. And there's a list of training on my websites that you could look at. But just to say that the way that I think about it is, first, is this person likely to be helped by ketamine at all? Number one. And number two, what dosing strategy or what paradigm do I want to recommend? And everybody's different.
awesome, thank you.
great. Thank you. Another question here is on the use of ketamine in a low dose daily for pain, and whether that might be, but it looks like you've already answered it, applied for depression, obsessional obsessional experiences.
Yeah, treating pain is outside the scope of my practice. So I'm going to defer to docs who are qualified to do that, who are trained to do that. It's my understanding I have a lot of colleagues and friends who are pain docs of various stripes, that they sometimes prescribe ketamine, lower dose ketamine, for daily use for a time-limited period of time to help people with acute pain in lieu of an opioid. But they also have a couple of requirements. Number one, that the patient demonstrates that they're responsible. Number two, that the patient is reassessed frequently. Number three, that the patient is participating in physical therapy in order to continue the ketamine prescribing. And I think that's really reasonable. I think we should be doing something similar in psychiatry and psychotherapy, which I actually outlined on my document about COVID. Renee, if you can find that on my website, that would be great. It's about prescribing lozenges. But all that to say is that something terrible is happening in the field, which has to do with mail order ketamine, which I think is being done in a egregiously unethical way, largely. I do think there's a place, very briefly, I do think there's a place for at-home ketamine use, but only in patients that you know well, where you're checking on them frequently, where the dose is low for safety reasons. And mostly it's done for financial reasons or as a bridge in between in-office visits. But the idea of sending people huge amounts of ketamine, either for psychedelic experience alone or for any other reason for treatment, is grossly unethical and is resulting in all kinds of adverse events, including, not limited to, hurting yourself, like falling down the stairs. I'm deathly afraid that there's going to be someone's going to hurt someone else, like in a drunk driving scenario, but utilizing some of these powerful medicines. People have all kinds of adverse psychological events. The majority of adverse events are psychological, actually, where people get triggered with ketamine into traumatic material that they weren't prepared for, and they can't get themselves out of it, and they're frightened. Death. I'm aware of multiple deaths that have occurred, including a couple of drowning accidents under the use of ketamine. Somebody who died in a fire while paralyzed by ketamine. And suicide, people who have injured themselves. Renee, could you please grab me the serious adverse events article and put that up? So I don't mean to imply that this is completely safe. It's not. It's relatively safe. It's quite safe when used in a supervised setting. And these are very powerful medicines. We have to use them with caution and respect. Do I have anything else I want to say about this? Yeah, this is a really tricky area and one that is troubling.
Yeah. Thank you. Thank you. We have a lot of questions, but I'm going to try and combine some of them. But for sub-psychedelic dose, do you use music as you would with a full psychedelic, or do you do it? Anyways, the use of music with ketamine is the question.
Yeah, so I have all my favorite stuff on my website. Renee, if you can go on my website and find that, that would be amazing. And It depends. If I'm trying to do psychotherapy, then probably not, no music. For infusion, often there's music. For psychedelic journeys, for sure there's music. The music is important. Here's a tip on music, a couple things. First of all, the music is distorted. It sounds faster under the influence of ketamine than it does ordinarily, and people can be paradoxically really sensitive to sound under the influence of ketamine. And I actually don't allow patients to bring their own music, because then their attention is distracted and they're fiddling with fast forwarding or next song or whatever. And I think that surrender is part of safe and consensual surrender is an important part of this experience. And so I've got playlists that are meant to walk people through or evoke different emotional flavors. And so I have some favorites. As I said, you can find it up there. Renee, I think can you get me the music link on my website? I don't think that's the one. Anyway, yes. And I encourage you to experiment yourself and see what feels good to you and see what's a good fit for your clients.
Great. Thank you. I love the fact that most of the answers you're saying go to the website. That makes me feel less guilty or upset that I can't ask you all the questions. Let me see.
That person in.
Sure, sorry. Letting someone in. But I guess, what are the accepted indications for use? And we are getting pretty much to the end of time. I feel like there's so many good questions, but accepted indications for use.
Yes, that's a question that takes more than 1 minute to answer. But
Right.
just to say that the big five, are the things that are well established in the research literature are the following. Number one, the patient has severe and refractory depressive disorder, so major depression over time, and has had previous treatment, and the treatment wasn't sufficient. I'm going to put a little star next to that because there's something more to say about that. The patient has bipolar depression or bipolar disorder, and they're on a antipsychotic or mood stabilizer on the top end of their illness to manage that, and they continue to have depressive episodes. That would be the next one. They have to be taking a mood stabilizing medication though. Number three, the patient has physical pain or physical injury causing pain with depression, which is a very common combination, sadly. The next one is the patient has obsessive compulsive disorder. And the final one is the patient has something called ruminative suicidality, chronic suicidality. And the hallmark of this is not just that they're suicidal, but rather that they're suicidal and it's distressing to them and it has an obsessive quality to it. I don't think it's appropriate actually to give ketamine to someone who is suicidal in response to an acute or clear stressor. That's different, that's something else. This has more of an illness feeling to it, as I said, with an obsessive property, and the ketamine is probably relieving the obsessive process. I want to say one more thing about this real quick, which is there's a question as to whether ketamine is appropriate and useful for people who are depressed in response to COVID or the whole horrible global situation such as it is, who weren't depressed before. And the answer is I don't know. What's been shown in the literature is people who are depressed over time, often for years and decades, as I said, who have a depressive illness, probably a hereditary one, that started as a child or in adolescence. So new onset depression or depression in response to clear stressors is a different category, and one I think that we're still trying to figure out what the role is of these powerful psychedelic agents. The answer is I don't know.
Mm-hmm. Right. Thank you. I'm going to take advantage of having you. And the question, you started to talk about ketamine and MDMA, and this will be the last question, just so people know. And I wonder if you could add a little bit more about that. You know, fair number of us here have been working at MAPS and with MDMA and have stories about comparing the two, and wonder hearing from you about that.
Oh yeah, each of these questions could be a half-hour long discussion unto themselves. But here's the short answer, I think, which is that serotonergic agents like MDMA, also psilocybin, also LSD to some degree, the way that I think about them is they have the potential to take the client, when you ride this horse correctly, it has the potential to take the client into an element of their own biological, or their own history. I mean, their own biography. That was the word I meant. To really get in there and really untie a knot and really like take a magnifying glass and really take a close look at something. But ketamine does the opposite. Ketamine works in the opposite energetic direction. Ketamine takes you away. It's glutamatergic, by the way, so in a different neurotransmitter pathway. These glutamatergic agents take you away from who you think you are, such that it doesn't really even matter anymore. And you realize that your life, that you are stardust, who is a grain of sand on the beach of the great ocean of life. And your story and what happened to you, it disappears into just being delightfully trivial. And so in that sense, it's a shift in perspective. The serotonergic agents go this way, the glutamatergic agents go this way, and they just sort of do different things. And what they do is, in a way, complementary. There's some question as to whether there will be a super antidepressant in the future, which will be a combination of MDMA and ketamine together. So I think there's some interesting potential there. So I'm going to, in the interest of restraint, I'm going to stop myself. But anyway, that gives you a little taste of how I think about it.
No, that's fascinating. Thank you. So you've whetted our appetites to learn much more about this amazing medicine. Thank you so much, Raquel. And maybe we'll be able to have you back at some point.